Hello and welcome to the second of our series of 3 webinars on governing in an era of accountability. Presented to you by Dr. Jim Rice of Integrated Healthcare Strategies and Kurt Waltenbaugh of Charettes Health. My name is Kelly Perkle and I'll be today's moderator. Just a couple of housekeeping items. All lines will be muted upon entry, and please submit questions on the right side of your screen in the text box. Feel free to submit questions throughout the presentation, but we will be answering them at the end of the presentation. Today's webinar is the second in our series with a focus on community health charrettes and engagement for community health partnerships. The first was recorded and is available upon request via email. The third webinar will be on December 6th at 10:30 a.m. Each webinar will open with 5 key messages and will end with 3 actions that boards should consider. Now I would like to introduce our presenters for today. Jim Rice is the Managing Director for Governance and Leadership located at the Minneapolis offices of Integrated Healthcare Strategies, a division of Gallagher Benefit Services. He works with large and small hospitals and health systems to enhance the effectiveness of their boards and physician leaders and has over 35 years of experience in integrated health systems in over 34 countries. Kurt Waltenbaugh is the founder and CEO of Charettes Health. Kurt has spent his career building and launching companies to better understand and influence consumer behavior, mostly at Optum, a division of United Health. Thank you both for being here today. Jim will be covering the first portion of our content. Please welcome Dr. Jim Rice.
Thank you, Kelly. As you can see on slide 4, the 5 messages that will be woven into our conversation with you during this webinar are very much, we hope, on the plates and in the minds of boards, executives, and clinical leaders of hospitals and health systems and accountable care organizations. This particular webinar is very much focused on some insights about how to do joint planning as a vehicle for leaders in the community with the healthcare organization and, in fact, the system of care providers to deal with 5 important messages. Working together in this joint planning, which we will be referring to today as a community health charrette, is to define gaps and goals in health status improvement and health care improvement, to look at designing and developing a roadmap of how diverse groups of people can work together in a collaborative way to achieve health gain, not just health care. A third message we will be weaving into our conversation today is to look at the need for and the nature of engaging diverse partners. We'll be offering ideas of some suggestions of how to reach out for a more inclusive joint planning process. The fourth message is that a real value out of this joint planning, this charrette approach, as one very useful and innovative and relatively new model of joint planning, is that it will generate an opportunity to mobilize diverse resources, and it also offers a structure and a discipline to monitor diverse results. Let's first begin with this particular model of joint planning that we're going to share with you in this webinar. It's the concept of a community health charrette. It's a French word that literally translates into a small horse-drawn cart or a chariot. It was used much in the past, like we see today, with groups of French architectural students assembling projects on the fly with diverse partners and inputs back in the 19th century. Over the last several decades in the United States and in Europe, this concept and approach to joint planning has been used, expressed, and extensively by urban planners and architects dealing with model cities and large, complex facility planning activities. Our interest in this webinar is to look at how these structures and strategies for joint planning called a community health charrette can be used for the benefit of moving communities and health systems and healthcare providers in a path forward to better health gain and better health care. You'll see on slide 6 some images from a recent charrette that was conducted to help engage a wide variety of people from a local community. This particular community was a rural community, but it's a process being used extensively in urban, suburban, and rural communities. The important thing to think about in the community charrette is the value chain that moves from creative engagement of diverse participants into greater opportunities for ownership, and that results in higher probability of execution and implementation. And in the center of this screen, you'll see that key to the implementation is to mobilize resources of people, new technologies, and money that allows the great plans to be actually put in place. One of the elements that underlies the value of this approach to joint planning, called a community health charrette, is the concept and the principles of boundary spanning. As we move into chronic disease interventions, as we look at value-based payments in the United States health system, even with the change in the new administration that will be coming in early 2017, the fundamental framework and drivers for change is based on the backs and in the minds and in the purchasing behavior of consumers. These individuals need value for money, particularly when they are spending more out of their pocket. So as we respond to value-based purchasing and contracting, and as we respond to the need to engage consumers along a continuum of care, the hospital, the health system, and clinics can no longer just do planning for themselves by themselves. They must work with other organizations. And as we see in slide 7, we need to build bridges to other organizations in the community that will be involved in the social determinants of health. That means principles of creative listening, appreciative inquiry, and boundary spanning are essential. The boundary spanning is to blur the boundaries between organizations, much like the cell membranes need to be semi-permeable to move knowledge, to move information, to move inspiration, and to move engagement going forward. On the last point on slide 7, you'll see that this kind of boundary spanning and engagement drives change through greater partner involvement and motivation. When we get diverse groups of people, and as we've mentioned in the earlier webinar, these groups include police, fire, physicians, community leaders from the school, from chambers of commerce, arts organizations, faith-based organizations. When they sit down in a charrette venue for joint planning, they need information. And shown on slide 8 is the type of data sharing in a circular concept that we believe is quite important to shape the planning for a charrette. At the top, you'll see that data needs to be gathered. We'll be going into more depth in just a moment in this webinar on the types of data. But this process of identifying data that we need to find gaps and opportunities for collaboration builds a sense of awareness, and it starts to lay the framework and foundation for ownership from diverse groups of people about the potential values that can come from joint planning. Moving around the circle, we go to communication among the different organizations and the leaders that are involved in the community planning charrette. This communication is not just two-way, but is a network of communications that builds a shared appreciation of the challenges and the opportunities for cooperation and collaboration. Those shared insights become a form of insight and data and information that can be stimulated through the discussion that occurs in the joint planning. The joint planning venue is important. We'll talk about that in a moment, and also the structured opportunities for small group discussions within the broader group lead to discussion where there's testing and feedback and exploring and learning from each other in the charrette process. That leads to further feedback, not just in the interactions of the joint planning process of the charrette, but it leads to follow-up and follow-through after the charrette, so that this kind of monitoring leads new information that will lead to further growth of engagement and growth of results. And the new insights from that sharing and feedback, in fact, generates new data, which helps the cycle continue anew and to remain vibrant and to grow from a qualitative as well as quantitative perspective on the results needed from such joint planning. As we move to slide 9, we're looking at the challenge of building relationships and developing trust. Not only is new information an essential ingredient for the joint planning process called a community health charrette, but it's important to understand that 3 features build and contribute to the value of this particular form of joint planning. Venue matters, the sincerity of the invitation for the people that are invited and included matters, and the style of appreciative inquiry or creative listening also matter. But all of these are dependent on a sense of trust that comes from people. We've found in conducting these charrettes that often the people don't know themselves, or their groups rather, even in small communities. The people that are involved on the boards of hospitals do not know the boards of people serving on federally qualified health centers, local boards of health, school boards, and chambers of commerce, as well as many other organizations that are going to be essential to the interventions that acknowledge the importance of social determinants of health, even going into creating jobs, housing, security and safe neighborhoods, and the underlying attack at poverty that is so essential to the development of initiatives for health gain and health care going forward. So trust building is a very important part. There's some mechanical things that we found useful. Name tags, make sure you build in plenty of time into the charrette process to allow introductions where they can talk about themselves, their families, their organizations, their frustrations, their dreams and aspirations. In other words, the charrette can't be done in a 2-hour session. The best charrettes extend from early morning into the late afternoon, and sometimes can go from a meal function into the evening. So make sure that you have plenty of time and that the venue accommodates plenty of high ceilings and open space for moving around. And we've found, and we joke about, it's very difficult to have lofty and big ideas if you have a tight and constricting venue. So also look at the style of facilitation as you go through this. Ask often for feedback. You do need facilitators that are both sincere in how they walk to people, ask for ideas, tease out the clarity of understanding of information that is being shared, or issues around problems or gaps, and very importantly, the brainstorming that can occur for new ways to approach joint planning and new interventions. Make sure that people come casually dressed and are relaxed and comfortable for this kind of an exchange, and make sure that everybody understands that there are no foolish questions. Everybody's idea is important, and it's often useful for them to see their ideas recorded on flip charts or on walls of knowledge that are developed in the course of these charrettes. So the results from joint planning to achieve community mobilization are essential. They must deal with diversity, but they also must deal with useful information as well. And we will be exploring further some of these elements in the rest of this webinar.
Jim, thanks for the innovative community engagement ideas based on all of your years of experience. I now want to turn the stage over to Kurt Waltenbaugh from Charettes Health, who will discuss the data inputs and their influence on this process of engagement. Kurt, thank you so much for being here.
Thank you, Kelly. So the output, of course, of the charrette and the joint planning exercise is really only as strong as its inputs. And data is the key here. Data to understand the consumer and understand the community that you serve is crucial to inform the charrette process and improve the effectiveness beyond merely the opinions of the stakeholders, getting to the actual behavior of the population. Strength, weakness, opportunity, threat analysis is a simple and approachable tool that's very effective for walking the team through an analysis of the situation. But to get there, we need to have some underlying information about the community that we serve and some baselines to pay attention to. Industry-specific survey tools like the National Health Interview Survey from the CDC, surveys from the National Survey of Children's Health, Community Health Needs Assessments, data sources like Community Commons and others allow you to get access to that underlying demographic data about the organization and the community that is important to understand. So the key is gathering this information outside your four walls. Who are the consumers you are serving today and who are not being served in the community? How does this information translate into an understanding of the drivers of health risk? There are several good sources for baseline information in the community, some of which we've listed here. But again, the need is to bring both qualitative and quantitative methods together for an accurate assessment and bring enough information to drive the strategic charrette process. So the important thing to understand is that data is not an end unto itself. How do we make it actionable? If the data is not actionable, it's maybe interesting to look at, but it doesn't guide us towards taking that next step. Data must be shared in a form that lends itself to taking an action. Simply sharing, for example, the number of consumers in your service area is a static fact, but showing growth trends by geography overlaid with health risk factors can direct actions for future organic or acquisitive growth. Projecting into the future, what actions do you need to take now to create the necessary change? A good example of this is environmental. If we add up access to healthy food deserts, limited nature park access, crime statistics, radon and lead exposure risks, these are some of the factors that show up in identifying nascent environmental risk within the health of a population. Those in high-risk situations show higher diagnosis for anxiety, obesity, ED, ER usage, and so on. Now, those downstream issues can be simply treated in your hospital, or as part of the joint planning exercise, you can engage across the community to alleviate the upstream causes and improve the health of the population as a whole. So what do some of those data factors look like? So remember, the drivers of health outcomes from our first webinar include environmental, social, behavioral, economic, attitudinal, some of which are listed here in this wheel. As you look at the physical environment, we may see things like walkability of a community, access to parks, proximity to a fitness facility or gym, air quality, and many others. As we assess the content behind each of these physical characteristics, that gives us a window into where the risks are for the overall community. Remember that consumers live most of their lives, almost all of their lives, outside of our health system, and those factors are driving upwards of 90% of their health outcomes. So pay close attention to risk around things like social isolation, mental and behavioral needs, substance abuse, housing, and these elements will inform your community planning process. Now, CARET recommends collecting that information as close to the individual or household level as possible, because there are significant variations at higher aggregations like zip code and county level, which can be missed and overwhelmed by simply using the averages. So one good example here, if we look at the wheel on social and economic factors, the social risk of social isolation. So one group that we worked with, a medium-sized health system, was interested in highlighting the social and behavioral impacts for their community assessment. By scoring each household in their region with a number of factors along the lines of unstable housing conditions, propensity to social isolation, solo commute time, financial burdens, regular voting patterns, and much more, we were able to map those who scored highest on this social risk index, pinpointing geographies with the increased risks of hospitalization, increased risk of drug, alcohol, and tobacco use, depression, and others. Capturing that detailed information allowed the health system board and executive leadership to focus intervention activities not merely on the downstream impacts to the health system, like ER staffing levels, but rather on community activities to combat the sickness of isolation. So this is an ongoing process to use data to shape and mobilize the community. We recommend an annual cycle to revisit that process, refresh the information, and publish updates. So as you go from visualizing the data to finding related factors around insights, connecting those to potential causes, that guides you to identifying the appropriate stakeholders and choosing the right path, the right strategic path, which guides those actions. Taking the action and measuring and validating the results of that action, of those steps, are ongoing throughout the year. Let's see this in action on the next slide. Here is an example, starting with a very simple fact at the top. The proportion of adults over 65 is high and growing. Over the next few years, we're going from 14% to over 21% of adults who will be in that age category. Well, what else do we know? We know that more than half are declining in health, in fair or poor health, and trending worse. So why is that? As we drill into understanding the causes, one cause is limited leisure activity. So what does it mean when we diagnose a community as having limited leisure activities? Well, that correlates to limited physical activity, which correlates to a decline in overall health. So now we get to who can help. Hospitals can't do this alone. Simply treating our elders for their current health status will not eliminate the overall health decline due to lack of physical activity. It takes a broad partnership across the community to not only identify those at risk, but also match them to the right interventions. In this case, coordinating education and community activities across diverse entities inside and, more importantly, outside of the healthcare system to alleviate the physical activity concerns.
Kurt, thank you. I now want to play some comments from Liz Auk from Countryside Public Health in rural Minnesota. She'll share with us her experience in participating in a community engagement charrette earlier this year.
I am the Executive Director of a 5-county community health department in Minnesota. Our staff recognizes the importance of leveraging the ideas and resources of all organizations in the community to protect and promote better health. We are particularly interested in working together for the health gains of the lower income and vulnerable populations in our communities. We recognize no single organization has all the answers or the resources for good community health. We are more likely to address the social determinants of health in a day-long charrette event for joint community planning. We recently participated in a community health planning charrette in Montevideo, Minnesota. We had awesome participation from the hospital staff, the Chamber of Commerce, policy and public safety leaders, school board members, and Countryside Public Health. This diversity of backgrounds and perspectives helped us to better define our health gaps and to establish more creative cooperation to improve our area's health status. This cooperation is also more likely to help us mobilize the money needed for bolder and more sustainable action.
Great. So really the three big takeaways here, well, the key message is the importance of engaging a really broad array of civic and business leaders, not just clinicians, in strategic planning and community needs planning. So diversity is key for a lively participation, and as Liz mentioned, people of all ages, races, religions, incomes, it's important to get a broad spectrum representation of the community. In charrettes that we have helped to facilitate, we have invited community business leaders, clergy, even a group of high school students, as they are not only your future patients, but also your future workforce. Small groups and discussion in small groups and then bringing some of those key ideas to the broader group will help define the gaps and opportunities that the community needs. And then follow up and follow through to help mobilize talent and resources. So really, as a group, identifying top action items and goal delivery dates will help engage the community in a plan that everyone can get behind.
Thank you, Kelly. As we wrap up this webinar and go to the fun we hope to have with you and us interacting on a series of questions, we hope you've heard 5 messages in this short webinar, and that will lead to 3 actions that we believe boards and executive leaders of hospitals and health systems will pay attention to. We hope you've heard that a diverse group with better data will help build a clear understanding of the gaps and goals for improvement at a community-wide level, not just in your facility or on your campus. The second message we hope you've heard is that the design of a roadmap to health, not just health care, must be forged by the interactions of a broad array of community leaders. This also is essential to intentionally invite and to reach out of your comfort zone to diverse partners of all races, faiths, backgrounds, demographics, and organizational bases for this participation. It's only through that broad engagement and data-based insights that we're more likely to mobilize the resources we need to sustain the gains and the impact that are so important for our communities and, in fact, for our institutions. And essential to that is to monitor the results and to celebrate progress to plan. So what should boards and leadership teams do about this? We'll close this webinar with 3 actions that we would like you to take into consideration. The first, we hope you've heard us say, engage diverse stakeholders. Be very deliberate in your inclusiveness. Do not go to the same old group. Make yourself uncomfortable with the folks that you invite in, and make sure those invitations are sincere and that you make it easy for men, women of all ages to take the time to come. So that may need child support and even transportation assistance to get into the charrette planning venue and process. Have them prepared in advance and make sure there's follow-up so that people see that their time and talents and insights are being well used and acted upon. The second action is to be prepared to nurture a continuous process. You won't do a charrette once. You'll be doing it, we believe, annually or certainly at least every other year in an extensive way to define the goals for community health improvement and to monitor results and to continuously refine that joint planning and the joint execution and implementation of that process, that journey toward enhanced population health. And finally, the third action is we would like you to consider that the joint planning and the community partnerships that come from the joint planning will not be sustained unless you have something that the collective impact movement refers to as a backbone organization, a small group of staff that are often part-time, can be shared from different organizations. Often the hospital and health system must be prepared to support some of that staff. And this nexus of leadership, this community hub, can help build the understanding and engagement that's so essential to not only have great plans, but that the plans actually get implemented. So this greater sense of ownership, we think, is an underlying result that is so important to these results to be sustained over time. We appreciate your involvement in this webinar and look forward to interacting with you now in some questions and answers.
Before we get to questions and answers, I just want to note on slide 19 that we have a couple of additional resources here, and all live attendees will receive a PDF of this presentation via follow-up email, which will also contain a link to the recording. So you can forward and share these insights with others in your organization. So now we would like to open it up for questions, and we've had a few rolling in throughout the discussion. Please, again, use the text question and answer panel on the right side of your screen to submit questions. So the first question is directed at Jim. Jim, have you found a high response rate to the Charette invitation?
Yes, if it's approached in a correct way, Kelly. If you just have an insincere or happenstance approach to groups that have not been involved with you in the past, they'll question your sincerity and they're less likely to participate. If you think of not just executives that are making the invitation, but board members or physician leaders that have the different segments and sectors in the community that they interact with in their non-working period, they are more likely to be recognized as extending a sincere invitation, and the participation, both the quantity and the quality, goes up dramatically. So think creatively about who you invite, but also how you invite them and who invites them, and then the participation goes up.
I think you're absolutely right. I know that we've seen a better response with not only an email invitation, but follow-up from someone, a more personal method of invitation, a phone call, or some stopping by a community meeting to invite the participants. So thanks for that. The second question coming in is for Kurt, and actually it's a pair of related questions. So how do you incorporate the community data into the Charette, and is the process of collecting community data expensive?
Great question. So the process doesn't have to break the bank. Let's address that first. If you're starting from scratch, it can take a significant investment on your own to build that capability. Many organizations choose to work with a partner who already has some of that data to keep the cost down. But the key is that once complete, you will have a better understanding of and a better use for your EMR investment than ever before. To integrate that data into the overall Charette process, really, again, the key is to make that information actionable, to turn it into visuals, right? We're not presenting spreadsheets. We're not just sharing lists of numbers that can overwhelm your participants, but really calling out key pieces of information in charts that colorfully can be presented in front of the audience to let them see what the community looks like and where that community is headed over the coming years.
Kurt, one thing that we found important, and it ties together the question Kelly found on sincere invitation in leading to sincere engagement. If, for example, you need information about the cohorts of children going through the school board, or if you want the school board and the school superintendent to share information that they're finding in classrooms and in their interactions with families about health gaps, and these can be opioid problems or violence at home, a good way is to ask them for that information. Have they done studies? Sometimes hospital board members and executive teams aren't aware of the studies that are being done by these other organizations. And that's a way to not only get better participation, because they're asked to bring some of that knowledge into the Charette process. And the same can apply to some of the other community groups. Where else could we turn to get information that may be outside of the walls of the hospital? School board, of course, could be one. What other might be available?
Great examples. Just following down the theme of the schools for a moment. So many state organizations, for example, in Minnesota, there is a state organization that surveys high school and middle school students and asks many of those questions about alcohol and tobacco use, violence at the home, sexual behavior, and other things. That information is shared on a school-by-school or community-by-community basis and can form yet another input into another window into the behavior of that community. Nonprofit organizations in the community also are constantly measuring the performance and the effects of their interventions in the community, and so those reports, and there's a lot of information out there, they're happy to share that information and make it more broadly accessible. Finally, from a qualitative perspective, as you exhaust the quantitative information that's been collected through other means, generating your own data. If it doesn't exist, get out there and do some polling, surveying, focus groups, host some preliminary sessions leading up to the Charettes where you ask members of groups within the community about specific things that you need answers to.
So in follow-up, how do you mitigate sensitivity in using some of this data
in this process, both within the health system that may be hosting, as well as some of the community data that you're asking for. Any tips about how to qualify how the data will be used in order to mitigate sensitivity with using that data?
That's a great question on two fronts. Consumers are concerned about sharing information, rightfully so, about their health status and worrying in some cases how that might be presented in the community setting and how that might be used. Similarly, there are many constraints from a HIPAA perspective and otherwise around how to use the information within our health systems and within those electronic medical records. In general, right, if your organization is sensitive about using insights from the inside the health system, not to worry. There is enough information available externally that you can accommodate missing EMR data as a start. And while understanding your own patients can help you to understand the impact your system makes in the market, the broader weight of actual consumer behavior provides an excellent starting point. But with everything, the key is to get into to make sure that that information is aggregated and anonymized at a level where it shows you a map to the community without exposing or highlighting or pointing fingers at specific individuals or groups of individuals.
Just one more point on preparation for the charrette that's so important. You can invite insights during the charrette from police officers, which we have done, where they talk about opioid problems or violence issues. But that's less useful if you cannot prepare it into graphic pictures or summary charts beforehand. So we all need to be prepared to extend invitations, gather data from diverse sources, but it has to be pulled together in a legible and readable and inspirational manner. As Kurt talks about, pictures and graphs are very important. So make sure you have enough lead time to invite people to bring data and insights, but package it in easy-to-digest ways and have people look at that as they come into this day-long joint planning process.
So typically when you're collecting this data, a question from one of our audience members, is the information being collected only used for charrette attendees? And as that data is collected and the charrette occurs and themes come out of it, how do you report data that was collected and or insights from the charrette out into the community? What's the best way to do that?
I have a couple of observations because I think that can be critical to the success of the whole process. We're talking about the charrette as if it's a one-day event, but of course it's a broader process that extends several weeks leading up to it and months and years after that. We didn't mention explicitly the media, but the media can be involved in participating as active members of planning the charrette, in the charrette, and following up on the communications after the charrette. Some of the public media, newspapers, radio, and TV have their own data and studies and polling that they have that can be brought to bear. They can announce that this charrette is underway because the joint planning process needs to be very transparent and open. You don't necessarily have the whole community engaged or participate in the charrette, although that is possible and can be done with over 100 people involved in this process. So you do need to communicate what you're doing, how you're doing it, who's going to be involved in it. The data elements should be posted somewhere on the websites of the participating organizations. You may write this up in, it could appear, the key conclusions could appear about gaps and challenges and approaches on billboards, on radio programs, in published documents that the participating organizations send out to their communication links. So the key message, I think, is bold and open and transparent communication and frequent follow-up on what's being done with that good effort.
That's right, Jim. I think we see very similar things, that the data, while it's very useful from a charrette process, to develop the trust in the outcome with the broader community who aren't participating in the charrette, the source of that information needs to be shared. Here's where we captured the information from. Here's a summary of what it looks like, and share all of that input that was useful in the Charette process, much like you would put into the appendix of your community health needs assessment. Share the detail, show the source, open the facts behind the scenes to allow the community to trust the overall results.
Trusting results is a key point, and credibility is a key point. It pains those of us on this webinar or in the audience that will look at it later from hospitals and health systems to realize the community doesn't always trust us. They think the work we're doing is self-serving, that we're not being candid enough about the gaps and problems, and where we, in fact, have made mistakes and not used the large amount of money flowing through hospitals and physicians and clinics for real health purposes. It's been frustrating for me over a almost 40-year career to find out that only 20% of the system engagement activities of hospitals and the broader health system contribute to health and social well-being. 80% are the other factors, which we can't get at unless we invite the other organizations and institutions and individuals into the process of identifying gaps and doing something about it.
I think that's a great point, Jim. It's really important to let the community know that this is happening, they're invited and involved, and that their opinions matter. A couple more questions before we have to finish up. One quick question on who is best positioned to facilitate a charrette like this?
Well, first, it should be somebody that has some experience. They're not trying to feed their ego, and they are not even trying to feed the ego and the image needs of the sponsoring organization, which often is the hospital or the health system. It should be somebody that is prepared to ask a lot of questions, to be sincerely interested in the opinions of people that are in this diverse gathering, and so that they actually walk to people, ask questions, sometimes repeat it, draw people out, all for the purpose of building a sense of consensus on challenges, but also potential solutions. And not everybody can be a good facilitator in these kind of community-wide planning. If you don't feel comfortable that you have that in your organization, look to some of the community colleges that may have faculty or graduate students that have done this before in other settings. Ask around and be intentional about the criteria of who you're looking for, and don't just turn to the same old person in the community relations or the foundation or the planning departments of the hospital, for example. Be prepared to think outside the box and outside the organization.
Sounds like some level of neutrality is also important. One final question. How, is a broad one, how can we make sure that something good and actionable comes from all this time and commitment that we're putting into this process?
I think really the key here is as you generate the actions that come out of the process, we need to put in a system in place to measure those actions and hold ourselves accountable for the results. There are a lot of, some of the skepticism that comes from the community about these processes is they see a lot of talk and a lot of recommendations, but sometimes very few concrete actions and steps taken that are followed up. But if you make the commitment to not only hold the event, but on a regular basis monitor the progress towards the actions that were recommended and come back to the community with those outcomes on a periodic basis, that's not only will you make more progress in the community, but you'll increase that overall level of trust and accountability.
Mm-hmm.
I agree completely. In addition to constant and consistent follow-up and celebrating progress, make sure that there are some early wins. We often use a simple technique called a 999 action plan in these kinds of settings, where we ask people, of all the things that have surfaced as opportunities in the charrette, what are some actions, 2 to 3 things that can be done over the next 9 days, the next 9 weeks, and the next 9 months? And then you better make sure that you publish that and make sure that it happens. So the last thing I would say is it begins with from the very beginning, the sincere planning to get it done. and also that you make sure that there are accountabilities, that it's everybody that participates should make a commitment to do something themselves to make sure that it happens. And through that, we're more likely to have the Community Health Partnership Charettes be better planned and receive praise for actual results that are happening.
Great. Well, thank you both so much for your time this morning and for all of your wonderful insights. To those who participated and asked such great questions, thank you so much. It really adds so much to this discussion. I want to remind everyone that our third and final webinar in this series will be on December 6th at 10:30 a.m. Central. And that one will focus on transforming the consumer experience and cultures accountable to the customer. And that word customer is one we'll be really focusing on. Again, if there's anything you'd like to discuss with us after, our email addresses are at the bottom of the screen, and we would absolutely love to hear from you. Thanks so much for your time today.